Ethical Perspectives on the News is produced by the Interreligious Council of Lynn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV9.
Good morning and welcome to Ethical Perspectives on the News. My name is Alan Diehl. I currently serve on the board of the Interreligious Council of Lynn County and am the Vice President of the Humanists of Lynn County. On this morning's show, we will be discussing end-of-life care and how to properly plan for it. The reality is that all of us, sooner or later, will experience this period of our lives or help someone else as they experience it. For many of us, however, even thinking about this part of our lives can be difficult, let alone talking about it or planning for it. That said, how can we as a society become more comfortable with and better prepared for this period of our lives? Here to help us with this question are three respected individuals from our community. If I could have each of you just take a few seconds to introduce yourself and tell us what you do and why this subject is important to you.
My name is William Galbraith. I'm a retired physician. I practiced internal medicine for a total of 37 years. 8 of those years, the first 4 and the last 4 were at the university hospitals where I did some teaching. But most of my career was spent here taking care of patients in Cedar Rapids and our surrounding community. So I've had a good time. I've been retired since 1998, and I've enjoyed still being active in some things medical.
Excellent. Good morning. Yes.
And I'm Steve Jackson. I'm in my 54th year of being a family law lawyer here in Cedar Rapids, and I'm with the law firm of Shuttleworth and Ingersoll. I was a patient of Dr. Galbraith.
Wow.
And,
Good patient.
yeah, well, he was a great doctor.
Excellent.
And I'm interested in this because in family law, we deal with the whole course of a person's life, and the end of life is something that we have to take into account and consider in representing the people.
Absolutely. Thank you very much.
I'm Steve Knudson, pastor at First Lutheran Church, downtown Cedar Rapids. We're right in the middle of the medical district next door to PCI. And when I came to the congregation, one of the questions asked me in those initial interviews were, what do you see as the relationship between a church and a medical community? What does a church have to offer? And I think that as we look at matters of end of life, not just simply the witness of any faith community, but I just think about all of the funerals and situations I've been involved with over the course of a career, and thinking about how to do a better job, simply as a spiritual leader in those situations as well.
Excellent. Well, again, good morning, and thank you all for taking your time to talk about what is a very, very important subject. So, kind of jumping right into it here, when we talk about end-of-life care, what are we talking about here? And anybody can jump in on this, but maybe Dr. Galbraith what are we talking about when we use the term end-of-life care?
Well, medical science and technology have done wonderful things to help us stay alive longer than we would have otherwise. But nonetheless, we still can't stop aging. And we're all aging, and we still can't stop dying. So as we look, and I'm old enough now, I'm in the December of my life, as I reflect on all of that, it's gotten more easy for me to think about my own death and the process that I want to leave behind for my family. I think that the quicker we accept the idea that we are going to die, we ought to have plans, not only documents that attest to a living will and picking surrogates or proxies to speak for us when we can't talk for ourselves, if we're too ill, delirious, and so forth. We need to make those plans so that there's less suffering. Not only the patient can suffer less, but the whole family, the friends that surround us, they can have a better life too if they're not caught into this idea of no plans, just keep them alive, and we wind up in really bad situations at the end of life if we don't have such planning.
Right.
I think, Doctor, I'm an old Boy Scout, and the motto is be prepared. And I think if you prepare for the end of the life, there's less anxiety, stress on the family. Those are really stressful times for a family. And so in my practice in working with families, we talk about the whole course of their life and try to prepare them for the end of it. And Alan, many times I've got clients who, after they're divorced or the child custody dispute is over, they start a new relationship. And so you've got to be thinking about how things have changed, and do I need to revamp my will, my medical power of attorney, all those sort of things. So it's all being a good Boy Scout, be prepared, I think.
I think also it's recognizing there's a shift in our thinking that has to happen, and that there does come a time when we, particularly at the end of life or at points where there is no more cure. Nothing more can be fixed, or we can't be fixed. And what does it mean then to think about the whole person and the shape of meaning and belonging and our experience when we reach that point where whatever ails us can't be fixed.
Yeah.
And so much of medicine, and I think just as a society, we are geared towards fixing things.
Yeah.
And this is reckoning with that time where we can't fix.
Yeah.
And as you say, are we ready for that? Can
Right.
we shift our thinking, our imagination about that?
So I think there's kind of three themes coming out here, which is, are we legally ready for the end of that period of our life? Do we have our living wills? Other things we'll talk about. Medically, what is the medical community doing to kind of provide that end of life care? And then to your point, Steve, how, as a culture, how are we approaching this conversation of death, and how can we get better at it and more comfortable with it? So those are kind of the three things that hopefully we'll talk about and explore a little bit over the next few minutes. But that is a question I guess I do want to ask, and I'll just throw this out real quick. How do you think, I mean, certainly end-of-life care is something we've been talking about in our country for decades, I mean, dating back to the introduction of hospice, and so it's definitely not a new subject, but how do you think it has evolved, and why do you feel like today it's more important than ever? Is there a difference, or is it just, it's always been important, it's still important, we just need to continue to have the conversation? Or do you think there's something unique about our current situation?
Our current situation, I think, is multifactorial. Again, science has given us tools that can extend life to a point of, I think, error. We can become involved with machines that will keep us going downhill very slowly, organs failing, mind gone, delirium. We wind up then attached to a machine so that we can breathe. We wind up so that we can be fed with a tube either through our nose, down our throats, or even in our belly attached to our guts. And we can have our kidneys dialyzed and so forth and so on. In 2010, there were 100,000 people in our country admitted to long-term acute care. And half of those people were hooked up to machines. So here we are, hooked up to a machine. We're in a room by ourselves often, maybe no visitors for a long time. We have our arms tied down so we can't pull the tubes out. We're always on our backs then. We develop sores in our skin, and so forth and so on. This can go on for years. Mm-hmm. As a matter of fact, half the people that are admitted to these long-term intensive care areas are on a machine for a year or less. So it's extremely difficult for the patient who might be conscious to have this happening, mm-hmm. and for the family that has to try to watch this, if someone's fortunate enough to have a family that cares, it's suffering, and
right.
It's painful. It's painful for everyone. So if we have made our wishes known, we don't wind up in this situation. Mm-hmm. And a lot of people besides ourselves, are saved all the suffering that you can imagine.
Absolutely. So a lot of planning to prevent situations like that can
Sure,
help.
sure.
And I guess to kind of to go from there, we use the term end-of-life care, and immediately we think of, okay, that period of my life a few months before, that I'm going to die. And of course, not everybody knows when they're going to die, and it's not always spelled out for us, right? Mm-hmm. But I guess there is a question of, and maybe there's some difficulty here of how, from a medical perspective, the difficulty in really determining when a person is entering that period of their life. I mean, it seems like the question is a little bit more difficult.
Well,
than it
there are certain diseases such as cancer, chronic heart failure, maybe kidney failure, that we can anticipate that the end-of-life care is pretty urgent, that there's a time period that we can expect death to come.
Yeah.
It's very, very hard to tell exactly when a patient's going to die. I've made my mistakes in my career, and I could tell you that sometimes I was very right, that there is a very limited amount of time that people can be kept going. We can stretch that out now. I'm repeating myself with modern technology.
I think it also, it's not just simply about the longevity of life, but the quality of life associated with it.
Absolutely, well said.
And I've known people who have chosen not to have interventive care so that they might have greater quality of life. That the side effects of a treatment and the limitations or the confinement associated with that was not something that they wanted to do, and they were comfortable. They felt they were comfortable about their relationships with their family, had a good sense of self, and they could say, I'm ready. And they were willing on the front end to sort of trade quality for some extended number of days. But we've had discussions on a community task force on faith and medicine related and talking about this issue, that oftentimes or many times when interventive care is removed, that people actually live longer, though that was not the intention.
Steve, I think one of the words you used was talking. And I think the family and the doctors and other care providers have to be talking with the people. The person has to interact with their family and talk all these issues out. And that's part of the process of coming to the end of life.
Amen. The documents themselves won't do it.
No.
It's the conversation that's necessary with the people that are going to be involved when that time comes for us.
That's right.
And that probably is both the doorway and maybe the impediment. That when our family or friendship relationships are healthy and good, we can have those conversations. When there are breaks or ruptures or distances, with those people, then that prevents us from having that conversation. So that in some ways, thinking about advanced care directives or the particular instruments that one might generate to make the plans to be ready, that the impediments to that may be more social, maybe personal, spiritual. It's not so much the technicality of knowing what to do, but being in a position with yourself and with others so that you can actually do it and have the conversation.
Yeah, and I think that's a good point. I mean, certainly these conversations are inhibited by cultural norms and family dynamics and all of those things. And I think it's important then, because for us as a society to recognize that when it comes to end-of-life care, when I'm talking about being treated by hospice or in a hospital, I mean, this is something that impacts all of society, right? So kind of going back to this whole idea of, eating healthy and living a healthy life has kind of, it impacts so many, because if you do abuse your body in some way, that ultimately has to be paid for by somebody, right, when it comes to treatment. And I think the same thing with end-of-life care. If we can, as a society, agree that these conversations are important and having our wishes known is so important, I think that will help. As an example, myself, in preparation for this show, I realized, what, I didn't have a living will, and I didn't have a health care directive. So today I met with my attorney, and it took 15 minutes, answered a few questions, and a few signatures later, I'm going to have it all set and ready to go. But and then
Good
for me,
for you.
Yeah. Well, but I've been putting it off for years. I mean, honestly, I've had it on so many to-do lists. But I'm thinking, well, how should I do it? How do I go about? How expensive is it going to be? Just the fact of having to think about it in general. And so one of the things we were talking about earlier in the lobby was, this idea of, a lot of times we think of end-of-life care being for older people, right, that are approaching that point in their life. But for me, I was thinking, well, what if the younger people took the lead on it, right, and got their living wills in order and put their advance directives in place as a way to kind of set the example for maybe an older generation, because younger people just aren't doing it. But that might help kind of facilitate the discussion. Is there any thoughts on that, or maybe just thoughts on how to better have these conversations?
I think the suggestion about having younger people do that is one way of normalizing the task of having those conversations, putting those directives in place, that it doesn't have to be something that you wait to the very end when there's so much intensity of feeling and the occasion itself. It becomes a little bit more, as you say, good civic hygiene.
Absolutely. So let's talk real specifics here, because we've kind of been dancing around the idea of planning for our end of life. So what does that mean? I mean, I've already used the term living will, advance directive. There's others. There's the medical power of attorney. Could I have maybe you, Stephen, just kind of help, just very quickly, kind of talk about the difference between these documents and really how important they are from your perspective?
Well, from my perspective, I have clients who are old, and I've got young parents. And so even for the young parents, I insist they get a will, a living will, so that their future for their child is planned out in case something happens to them. But there's really, Alan, 3 different types of declarations. One is a living will, which indicates that if there's no chance of recovery or and death is imminent coming up, then no life-sustaining procedures are used. Now, the physicians, the healthcare providers can make certain that you're comfortable, you're pain-free when that declaration is put into effect. And you can tailor it to your particular beliefs about no resuscitation if that issue ever came up. And then there's the medical power of attorney, which gives somebody else the authority and the power to make medical decisions about you if you're not able to make those. And probably the last declaration is one that the funeral homes really like you to have, directing that somebody make arrangements for your remains and for your final ceremony. So those are the 3 general areas. And
so the advance directive is kind of rolls up underneath the living will then?
Yes.
Okay.
Right.
Very good.
So, Alan,
Yeah.
you've made the first big step now as a young man.
That's right.
And now the big one comes. You have to find the surrogates. You probably need 2. One that's a primary person to speak for you, and somebody to back that person up in case they are unable to fulfill their responsibilities. It's really important to have somebody really willing to make the really difficult decision to end life and avoid some of the things I've mentioned before, the breathing machines and so forth.
It does make you create a short list of your friends, like, who would I trust with that? It really makes you wonder.
And it can be also that the person that you designated may not be comfortable doing that in that moment. They might say, yeah, I'll do that, but in the moment they can't, or it's difficult to, so to have somebody else available to do that.
Yeah.
or part of that list would be important as well.
So so I guess, let's say I've got this all set up, a person has set up their living will, they've gone about it. What is the best way to make sure that those directives, that living will is followed? Because, a piece of paper is only as good as whose hands it's in, right? So what is your advice to people that are really concerned that this is followed?
You have to talk to your primary care physician, and you have to talk to other providers that will be involved with making those decisions with you. And your proxy, of course, family, friends, and clergy, so that you don't get into the position you're too ill to do so yourself when the time comes.
So your comment for that, Bill, is the more the better.
The more the better.
In my practice, I make certain that I send the living wills around to the healthcare professionals, the hospitals, and make sure that all of the family get copies of all of them. And they should not put any of those in a safety deposit box, because you may need them in the evening time when the bank or credit union's not open.
Very good.
And I think your comment, Bill, is that it's not about simply giving them a piece of paper, but it is about having the conversation.
That's absolutely essential.
Especially with family
Essential.
members.
Yes.
We've had some preliminary conversations with our adult children, and it's a difficult one, more difficult for them than for us, because they're all of a sudden having to think about that day when we're no longer here, and they're not ready to think about that. So to even talk about it surfaces a range of feelings and responses that are important, but in some ways still secondary to the matter at hand.
And that's why I like the idea of having it be a team effort, right? If the child can kind of do it, can draft their living will in conjunction with their parents, like, hey, this is important for So now, I guess I want to talk just very briefly about why is it important that we have these in place? Obviously, there's the just well, you need to know what you want, but why is that important? How does that impact our medical community and society as a whole? If people just don't have these in place, what are the repercussions of that? So, what is the incentive for people to have this? Well,
the alternative is a full court press to keep you alive as long as possible. Alive in quotes, because you might not be conscious. That's what must be done if you don't have directives. Mm-hmm. The law is such that physicians are obliged to fulfill using every technique they have to preserve life.
I've seen numbers where it's tens of billions of dollars keeping people alive kind of artificially, right? Where if they had proper planning, that wouldn't have to occur, and that money could be maybe better spent other places, researching diseases and so on and so forth. So, the benefit to society is real, it's tangible, and so the more people can kind of plan for that period of life, the better for everybody involved, right? Their family, their loved ones, people that care about them, but also in society. So there is going to be some graphics put up on the screen here that kind of give some information people can go to when it comes to getting educated on how to plan for the end of life. So please look at those. Very, very important. Do not hesitate. It's a very simple process. And, my dad always said, proper preparation prevents poor performance, and I think that's so key here,
that's
right?
A pearl.
So the 5 Ps of end of life planning. But so I do want to talk a little bit about, and then I want maybe at the end here, Steve, just have you talk a little bit about the initiative here in Cedar Rapids with the MedQ, because I think that's a very important part of our conversation. But talk a little bit about, if you could, Dr. Galbraith, about what is the evolution in end-of-life care from a medical perspective? How is that advancing? How are we making it more comfortable for people from a medical perspective?
By education, starting with young physicians who are now trained to be better able to speak to patients about these things, having a better sense of ethics. The idea of autonomy must be thought about, so must joint planning together with the caregivers, the physicians and others who are going to be there. So I see over the years a very healthy drift towards getting this done, but it's going to take a long time. Like seat belts, it took 20 years before almost everybody now buckles up.
Right.
So there'll be a time when we can diffuse this idea into communities.
Yeah.
And the more we talk about it, the better.
Yeah, now, we're running a little bit out of time. It's just escaping us here. And I do want to save just a couple minutes for you, Steve. But I do have one key question that I think is interesting. So many people believe the medical community's primary responsibility is to prevent death by any means possible. How does the medical community normalize the process of dying without being perceived as promoting death, right? So there is that kind of underlying, well, why would you have been concerned about this? You know, really, this should be for others. So how would you respond to maybe that kind of critique?
Physicians really don't want people to suffer. They don't want people to have pain. They want people to get out of that terrible loss of quality of life that can happen if this doesn't happen. So we have palliative care now that works on making suffering minimum. Nausea, vomiting, pain. Medicines can be used by specialists now that can take care of stopping that. We have hospice care that makes the end of life much smoother and easier for people. So gradually we're making steps towards physicians understanding this. Physicians don't want people to suffer.
Right.
They really don't.
Yep.
They want helpers to come and be involved with making life better.
Yep, absolutely.
We're getting to the point where the idea of quality of life is very important, not quantity of life, as Steve mentioned.
And
earlier.
certainly the medical community has contributed to the quantity of life too, as seen by, you know, how old people are living on average. But
maybe we've overdone it a bit.
Yeah. So we got just a couple minutes left.
Okay.
Steve, could you talk a little bit about what we're doing here in the community to address this? And then, you know, as part of that, maybe talk about, you know, how we can better talk about death.
Sure. First Lutheran is a part of a medical district designated with the 2 hospitals and multiple clinics in Cedar Rapids, and we formed a ad hoc task force for faith and medicine, exploring the interactions of between just simply the physical care, but also caring for the whole person. And by bringing people from a variety of professions, backgrounds, points of view of interest, that we can maybe, that area of that medical district can have a concern for the whole person. And the first item that we picked up to address was about end of life, care at end of life. And so we've created 3 presentations this fall, speakers speaking about that. And our goal as a task force is to help people to take the initiative to complete those advanced care directives, and then to look at the system issues in the community, so that for hospitals and the legal profession, that we can facilitate and we identify also maybe some of the impediments built in that we have that need to be addressed, so that not only do people have an advanced care directive, but that it can be implemented and used. And
Excellent. Very good. Well, it sounds like we're being proactive, and appreciate that. And again, gentlemen, thank you for your time this morning. And again, I hope you'll join us next week for another episode of Ethical Perspectives on the News. Have a great day.